Bismillah wa salatu wa salam ala Rasulillah. On behalf of SSPI, Sudanese Society of Breast Imaging, good evening everyone. I'm honored to welcome you all to this important educational webinar on Lynch syndrome. Today's session promises to be both insightful and clinically relevant, shedding light on the condition with critical implications for women health and cancer screening. It's my great pleasure to introduce our esteemed speaker, Dr. Rabab Mohammed Al Hassan, a highly respected figure in the field of radiology. Dr. Rabab, MPPS from University of Khartoum, followed by MD in radiology from the same institution. She also held fellowship
Nihat,
by College of Radiologists.
mute yourself, please.
Okay.
Other than Nihat, mute yourself. Who is talking? Okay.
Dr. Rabab, the flat is yours. Welcome.
بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على سيد الخلق أجمعين حبيبنا ونبينا وسيدنا محمد صلى الله عليه وسلم. Hello everyone and welcome to our today's session about Lynch syndrome. Outlines of this lecture include introduction, what is Lynch syndrome, why does it occur, and which cancer are involved. The case examples of different Lynch syndrome cancers, mainly the Lynch syndrome endometrial and ovarian cancers. Then we'll discuss it, the breast cancer Lynch syndrome, when or not. Why do we present this case and discuss Lynch syndrome? Our case is suspicious of Lynch syndrome. Why do we suspect Lynch syndrome in our case? And management of Lynch syndrome, including diagnosis and treatment, and then summary and key messages. So, what is Lynch syndrome? Lynch syndrome is also known as hereditary non-polyposis colorectal cancer or HNBCC. It is a genetic condition that predisposed to not only a colorectal cancer, but also a variety of other malignancies are involved, with a lifetime risk of getting cancer approximately 70 to 80%. It is an autosomal dominant. That means requires only when affected allele of DNA to occur, and the condition is passed from parents to children with a 50% chance of having it. Though it is the most common hereditary cancer syndrome, it is a rare condition with an incidence of 1 in 300 to 1 in 200,000. Lynch syndrome is subdivided into two types. Type 1 or the HNBCC1, which is also called familial colorectal cancer, in which the colorectal cancer is going to be predominantly the only cancer occur in the family. The other type, or type 2, Lynch syndrome, have a mnemonic CEO. C refer to colorectal cancer, E refer to endometrial cancer, O for ovarian and for other malignancies. So in type 2 Lynch syndrome, individual have getting risk in general. And we can see other types of cancer in family, and with order of frequency, the gynecological cancer are far common after colorectal cancer than other types of cancer, which include stomach and small bowel, urinary tract cancers, and then brain, biliary, pancreas, and prostates can be involved. And the remaining question is about breast cancer. Is it Lynch syndrome type or not? Let us see what is being reported in the recent literature. Okay, what about the pathophysiology of Lynch syndrome? During the course of life, as you know, there are cell division in our bodies. See? And there are many factors, environmental, diets, etc., okay, affecting the gene, the DNA, resulting in some mutations like radiation, ultraviolet violet radiation, like smoking, alcohol, some diets, and so forth. Okay, so during this division, some mistakes occur. And these mistakes called mismatch. So there are certain proteins in the body are responsible of repairing these mistakes, okay, called mismatch repair proteins or mismatch repair genes, okay? Can you see here in these illustrations? There is a defect here, or there is mistake. The gene detect this mismatch, and here in the process, they have done some excision followed by resynthesis, ligation, and then final repair. So these genes are defected in Lynch syndrome, which include MLH1, MSH2, SH6, and BMS2. These are responsible for the repair, as we mentioned, and when being defected in Lynch syndrome, so they cannot do their function properly. And then, as we can see here, the gene, when the gene is intact, the mismatch repair gene intact, we can see equal replication nucleotides. But when it is defected, it can result in some defect or mistakes. These cells showing 3 repeats of nucleotide or allele size of DNA, while the others demonstrate 5. So this is called instability, okay? And in the regions of genome called microsatellites. Definitely, if these genes are not well, are defective, there will be an issue regarding their job or their functions in repairing the mismatch or mistakes during these replications of the DNAs, okay? And this, it will accumulate by times, okay? And or over time, and these accumulations result in it is the oncogenesis occurs like that, or the process of oncogenesis of Lynch syndrome. In colorectal cancers, you know that there is adenoma carcinoma progression, and this is usually in sporadic colorectal cancer takes long times from 10 to 15 years. As we can see here, you see in this illustration. But when there is microstability, okay, like in these genes, as we described in the previous illustrations, then it will accelerate, okay, the process of the adenoma carcinoma progression. It will happen during a shorter time period. So it will result in the ratio of adenoma carcinoma in Lynch syndrome, it will be 1 to 1, while in the sporadic cases, it will be 30 to 1. Okay? So let us go for case examples of Lynch syndrome cancers. And definitely, as we mentioned, the commonest is colorectal cancer, followed by gynecological cancers. Then stomach, small bowel, and urogenital and urothelial cancers, followed by other types of cancer, brain, prostate, biliary, cholangiocarcinoma, and even skin cancers. And recently, also they mentioned link between thyroid cancer and Lynch syndrome. Okay, here we can see example of right colonic cancers in a patient only 22-year-old, okay, man with a large mass in his ascending colon. Here in the axial and coronal view. And they found that the right colonic cancer incidence in Lynch syndrome is up to 80%, range from 60 to 80%, while in the sporadic cancer, as you know, the left colon is predominant, with only 30% of right colon is involved. And here we can see a metastatic, lymph node post-surgery taking very high uptake. Okay, the Lynch syndrome has emerged as the most prevalent cause of heritable colorectal cancer with a lifetime risk up to 80%, and it represents 2 to 5% of all colorectal cancer diagnoses. And as you know, the cancer generally is a disease of old age, and the median age of colorectal cancer in the sporadic types is 69, while in Lynch syndrome usually presenting early with a mean age of 43. Here in this case, a woman in her 60s with Lynch syndrome. She has a family history of colon cancer in her daughter, uterine and gastric cancer in her sister, and colon cancer in her nephew. Okay? What we can see here, the endometrium is distended with hypo signal mass or low signal T2 mass. Okay? It is obviously seen here if we can trace. This is the myometrium, and here we can see extend beyond the 50% of the myometrial thickness, and with indistinct of the junctional zone. Here it is hypo enhancing. Okay, it is a hypo enhancing, and here we can see a rectal mass at the same time. So this image demonstrates rectal cancer as well as endometrial cancer in this 60-year-old lady with Lynch syndrome. And here, this is the post-surgical specimen demonstrate grade 1 endometrial carcinoma stage 1B with myometrial evasions. The rectal cancer was type 2 tubular adenocarcinoma infiltrating beyond the muscularis propria, as well as a third cancer of the cecum was not included in the view of the previous image, but the patient also had a third cancer in her cecum. This is another patient of, she is a 47-year-old. She's young. She has endometrial cancer also, but not in the typical age of the sporadic endometrial cancer. As you know, also it is a postmenopausal cancer, occur in the age of 60s and above. And this is young lady presenting with heavy menstrual bleeding, and they found abnormal cells in her smear testing. Then this her MRI demonstrate a large slightly hyperintense mass infiltrating the myometrium and the cervix. Here, this is the fundus. Why? We can see the fundus posterior to the cervix because it is a retroverted uterus. Can you see this is the fundus? And here we can see the mass in the region of the lower body of the uterus as well as in the cervix. And this is a distended area is the vagina. Okay? And the patient was examined for possible Lynch syndrome. Okay, she's a young lady, and because her age, and she has 2 siblings, were diagnosed with colorectal cancer before the age of 40. And she was found to have MSH2 mutation carrier, which is typical of Lynch syndrome. So in female Lynch syndrome patients, increased risk of colorectal cancer is accompanied by increased susceptibility to gynecological cancer, especially or particularly the endometrial and ovarian cancer. And the Lynch syndrome is the only heritable cancer, heritable cause of endometrial cancer. Okay? It is the only heritable endometrial cancer with a lifetime risk ranging from 16 to 71% compared to 2.6% only of general population risk or the sporadic cases. So it has very high lifetime risk of endometrial cancer, up to 70%. And Lynch syndrome represents 2.5% of all endometrial cancer diagnoses. And as we mentioned earlier, it is a postmenopausal disease. Usually the median age is about 60-year-old, but for the Lynch syndrome cancer, usually seen in younger age group with a median age of 49 years. So, endometrial cancer in Lynch syndrome, due to strong link between Lynch syndrome and endometrial, along with colorectal cancer, the UK National Institute of Health and Care Excellence recommend that all patients with colorectal or endometrial cancer should be tested for Lynch syndrome using immunohistochemistry or microsatellite instability. Next patient. What we have seen here, what is going on, Nihat? Can you see what is wrong in this image?
Yes, Hebus. There is a slight invasion of the urinary bladder,
Mhm.
and the prevertebral space.
There is what?
There is invasion.
Invasion by what?
Yeah.
Here,
Of the
what?
mass.
Which mass? Where is the mass? You have to start by the pathology itself, yes?
Okay.
Uh-huh.
There is a tumor. The first image is T2 image.
Uh-huh.
It has low signal on T2.
Uh-huh.
It has two foci
Uh-huh.
in the myometrium.
Okay, this is a large pelvic-abdominal complex cystic mass. This is T2.
Okay,
It is obvious here. We can see the urinary bladder. And this is the large complex cystic mass. It is predominantly cystic. It is bright on T2. Okay, but we can see some level. Okay, here fluid levels or something. And there is soft tissue component, papillary projection from the wall, make it highly suggestive of malignancy, okay? And on T1, this is the posterior dependent fluid is seen as low, but the anterior component is still bright, reflecting fat, okay? It was fat, and so since the ovarian mass containing fat is going to or suspecting to teratoma. But at the same time, there are suspicious or highly suggestive features of malignancy. So still teratoma can be associated with cancer. And this lesion was proven to be a mucinous carcinoma associated with mature teratoma. The mature teratoma is benign, but there are association between a benign and malignant lesion at the same time. Okay, this is mucinous adenocarcinoma and mature teratoma. Okay, this patient 3 years later, she had this CT with localized thickening of the cecum or the ascending colon, again on her right colon, okay? Indicative of colorectal cancer, proven to be type 2 tubular adenocarcinoma, okay? And look for the age of the patient. She is in her 20s, still in her 20s, okay? She has colorectal cancer and ovarian cancer at the same time, and then in her follow-ups, definitely these type of patients undergo regular checkup, but fortunately she has no evidence of recurrence. Another Lynch syndrome ovarian cancer patients. You see, not only ovarian cancer here, what we have seen, this is a uterus, and this is ovarian or right adnexal mass taking strong uptake, okay, here. And not only that, look for this CT. Usually we might pass it, just we might pass it as a small fluid in the endometrium or mild endometrial thickening. But look for the bed of the same structures or of the uterus, the endometrium, the thickened endometrium demonstrate avid FDG uptake, okay? And it was proven to be endometrial cancer. And not only that, look for this ascending colon, okay? Here, that is a mass, okay? Look for the uptake, avid uptake, FDG uptake, okay? And this is 47-year-old woman. She had history of right lower quadrant pain and dysfunctional uterine bleeding. She had ovarian grade 2 ovarian endometrioid adenocarcinoma, grade 1 endometrioid adenocarcinoma of the endometrium, and adenocarcinoma of the ascending colon. So, the risk of ovarian cancer in female with Lynch syndrome range between 6 and 12%. Whereas the risk of ovarian cancer in general population or the sporadic is only 1.4%, okay? It is high, but not like the endometrial cancer, which is 70%, or the colorectal cancer, which is 80%. So the mean age of ovarian cancer, the same as other cancer, is 63%, is 63-year-old, but in Lynch syndrome, definitely it will be at a younger age, with the mean is 45-year-old. So Lynch syndrome is one of Lynch syndrome is one of the genetic diseases of reproductive organs, but we are not going to talk at current time because it is out of the scope of our lecture. Maybe later we'll talk about this genetic condition of reproductive organs. Okay, this is patients having gastric cancer, 65-year-old woman with a Lynch syndrome with a germline loss of or a defect in MLH1 and BMS2. She underwent colonic cancer resection 21 years earlier. Yani after 21 years, she developed from resection or from treated colorectal cancer when she was in her 40s. Then she developed gastric cancers. Okay, here we can see near circumferential gastric thickening taking avid FDG uptake. And this again, urothelial cancer in Lynch syndrome patients, 50-year-old man having germline loss in MSH2 and MSH6 underwent surveillance CT after resection of colon cancer a year earlier, 1 year earlier. After 1 year, this is a survey, CT follow-up. They found that he has left hydronephrosis with soft tissue in the left distal ureters, proven to be urothelial cancer, one of the commonest Lynch syndrome associated cancer. Another example of Lynch syndrome associated urothelial cancers. Can you see it here? You see, these are urothelial cancers, and this is metastatic adenopathy. Okay, this is this patient has known Lynch syndrome and had prophylactic colectomy. Okay, presenting by a mass in the duodenal junction, confirmed at laparotomy to be adenocarcinoma. Another example of Lynch syndrome, duodenal cancer at the third or transverse part of the duodenum. You see here, infiltrating into the adjacent structure, avid FDG uptake, invading the adjacent mesentery and pancreas in a 63-year-old man having history of 3 primary colon cancer. 3 times he had colonic cancer diagnosed when he was 35, when he was 40, and when he was 53-year-old. Okay, treated for 3 primary colonic cancer and for duodenal cancer at the age of 46. And now he has a second primary duodenal cancer in his age of 63. And also at the age of 58, he had transitional cell carcinoma and found to have mutations of MSH2 and MSH6. Okay, so Lynch syndrome associated cholangiocarcinoma, also one of the Lynch syndrome associated cancers. Here are 2 examples. Here, this is enhancing mass, very obvious in the porta hepatis, but this is very subtle. Okay, also at the bifurcations here, or the hilum, with intrahepatic bile duct dilatations, hilar cholangiocarcinoma in a 61-year-old man presented with obstructive jaundice. Okay, he was treated for colon cancer 19 years earlier. Before 19 years was treated for colonic cancer. Okay, and found to have MLH1 mutations. Okay, Lynch syndrome associated pancreatic carcinoma. Okay, a 5 centimeter ill-defined hypoenhancing mass at the tail of the pancreas proven to be adenocarcinoma in a 56-year-old man presented with symptoms of anemia and treated for sebaceous adenoma in his 40s and for duodenal cancer at 47 years. Also, this is sebaceous adenoma, one of the associated Lynch syndrome lesions, and the tumor occlude here. The tumor occlude the splenic vein, and the patient was found to have germline mutation in MSH2 genes. Okay, and here this is glioblastomas. 3 patients having Lynch syndrome. We can see the aggressive types of lesions with necrosis and perilesion edema. Okay, in all these 3 patients, you see, and the first one here is 66-year-old who presented with new seizures. Okay, he was treated for colonic cancer 19 years ago. Okay, and the patient was found to have MSH2 mutation. Okay, so what do you think about the breast? Is breast cancer a Lynch syndrome or not? Who is available here from breast specialized people? Mr. Ghassan.
Is Ghassan available?
I think so.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
كيف أخبار؟
الحمد لله.
أنا arrived يعني قبل 5 دقائق كده. لقيتك I found that you are speaking about Lynch syndrome.
Yes.
And your question is about the incident of breast cancer with Lynch?
Is it breast cancer a Lynch syndrome cancer or not? Is it there is link between breast cancer and Lynch, or there is no link? Because there are certain types of cancer are considered to have.
Like breast is not one of the main cancers associated with Lynch. They might have an increased incident, but I don't think it's is that high or is known to be very high, because they are not included in the high-risk cancer patients that need a special surveillance or screening, as far as I know.
Okay, let us see what is reported in the recent literature. Okay, agree
Yes.
with you.
It is changing, Lakin. There is more and more evidence.
Who is talking? Wala
Nadia.
or whom? Dr. Nadia, you are welcome. Yes.
Nadia, ya Rabab.
Yes, yes. What?
Just from the literature, there seem to be more and more cases, especially recently, 23 و 24,
Yeah.
there are more and more cases, yes, being reported.
Yes.
So eventually it's going to join
Yes.
the others.
I brought some breast cancer cases associated in Lynch syndrome patient. This is Lynch syndrome in 30-year-old African American woman presented with right breast pain and swelling and bloody nipple. No, not bloody nipple. Sorry. This is palpable abnormality. You see, it is indistinct mass on mammography, rounded, high density, seen on ultrasound as complex, solid cystic, 4 centimeter lesions, aspirated, and on MRI here it's obviously demonstrate an irregular rim enhancement, and the blood fluid was aspirated from ultrasound lesions and proven to be poorly differentiated triple negative invasive ductal carcinoma with extensive necrosis. And the patient referred to genomic counseling and a mutation suggestive of Lynch syndrome. Another patients here, 59-year-old woman with history of Lynch syndrome. Okay. On mammography, she had a speculated mass at 6 o'clock positions in the right breast with corresponding ultrasound findings of irregular, deeply hypoechoic mass measuring 2.6 centimeter. Okay, MRI demonstrate heterogeneously enhancing mass proven to be triple negative invasive ductal carcinoma. Okay, the third case, this is recently published last year. A patient with coexisting breast cancer and sebaceous carcinoma of the breast with a background of Lynch syndrome. Okay, she's 54-year-old, presented in January 2023 with right breast lump, and she has past history of locally advanced colorectal cancer 15 years ago, treated with right hemicolectomy and adjuvant chemotherapy. Okay, and due to her young age at colorectal cancer, was genetically tested. 5 years later, found to have Lynch syndrome, and underwent risk reduction prophylactic hysterectomy with oophorectomy, okay, as per guidelines, which were tumor-free. And here we can see the mass on mammography, and here the mass on ultrasound definitely is very suspicious. Maybe on mammography it is only it is faintly or barely visualized, but they didn't bring the tomosynthesis, which demonstrate an ill-defined obvious mass, and the mass definitely on ultrasound here is highly suspicious or malignant type of mass proven to be also triple negative adenocarcinoma. See, and 2 years before her presentation, right breast palpable abnormality, she had a skin lesion in her left breast with ultrasound suggests just an inflamed sebaceous cyst, was not biopsied because of typical appearance. But because of the risk factors of the patients of Lynch syndrome, the multidisciplinary suggest to have bilateral mastectomy instead of only treated her right breast, and post mastectomy revealed triple negative. Again, this is a third case, also triple negative breast cancer, okay? And they found in the lesions BMS2 and MSH1, typical profile of Lynch syndrome in the breast tumor. And the skin tumor proven to be a well-differentiated sebaceous carcinoma. It was not a benign one. I will leave the histology for you by the end of the lecture, Dr. Nadia, to comment on. Okay, the case number 4 here, this is a 49-year-old female who since September 2003 experienced uniform loose stool mixed with mucus, small blood and mucus, and diagnosed to have sigmoid mass on the CT, proven to be malignant mass with adenopathy, underwent resection of the tumors, and proven to be poorly differentiated, 5.5 centimeter poorly differentiated adenocarcinoma with vascular but no nerve invasions, 9 out of 19 metastatic lymph nodes. And the immunohistochemistry demonstrate positive result for BMS2, MSH2, MSH6, and MLH1, almost all gene for Lynch syndrome. So this patient before 10 years, as we mentioned here, the patient in her 49-year-old. When she was 39-year-old, she presented with hard finger-shaped palpable abnormality in her right breast. By imaging was highly suspicious. Biopsy revealed grade 2 invasive ductal carcinoma and DCIS, treated with mastectomy and proven to be grade 2 invasive ductal carcinoma, modified radical mastectomy, which was BR positive, ER positive, and the other factors here and genetic detections, oncogene B53 and drug-resistant gene TOPO2, and so forth. And she received adjuvant chemotherapy. The same patients. Now she's 49-year-old. She had current history of, or she diagnosed with rectal cancer in September 2023. She has 10-year back diagnosis of breast cancer, and she has family history of cancers. She has siblings affected with hyperthyroidism, and two sisters diagnosed with breast cancer, and the emergence of secondary rectal cancers with lymph node metastasis aligned with prototype features of Lynch syndrome. They mentioned that in this case, a patient suffered from breast cancer 10 years ago and was subsequently diagnosed with rectal cancer, which is different from traditional Lynch syndrome development, because usually the patient presents with colorectal cancer first, but this patient presented with breast cancer first and then colorectal, and they found that even the breast cancer considered to be is going or is aligned with Lynch syndrome. And the patient adhered to regular follow-up, and fortunately she is free. So this case reported in the World Journal of Clinical Oncology in September 2024, and they reported that breast cancer serve as initial symptoms in approximately 40 to 60% of female patients with Lynch syndrome. Also, it is the most prevalent extraintestinal manifestation of Lynch syndrome. And in this case, the patient was initially diagnosed with breast cancer, and subsequent discovery of rectal lesion coupled with genetic testing result led to consider of Lynch syndrome. And Lynch syndrome breast cancer typically present between the ages of 46 years and 54 years, featuring diverse pathological types with tendency toward low differentiation. The patient who was diagnosed with breast cancer at the age of 39 years exhibited adenocarcinoma aligning with the characteristic feature observed in Lynch syndrome breast cancer. The patient in this case was diagnosed with breast cancer and then was diagnosed with rectal cancer a decade later. Thus, it is imperative to closely monitor and screen for the potential occurrence of other disease in the future, and prior studies have extensively reported mutations in the MLH1 and MSH2 genes in a case of breast cancer. They mean with this patient exhibiting a pathogene mutation in the MSH2 genes. Okay, and diagnosing Lynch syndrome breast cancer can be challenging, leading to experts to recommend comprehensive screening measures for all newly diagnosed breast cancer. So there has been conflicting evidence in the literature regarding the link between breast cancer and Lynch syndrome. Okay, and the development of the Lynch syndrome related to breast cancer is also complex and leading to personalized variations in diagnosing and treatment plan. And the risk of breast cancer in Lynch syndrome, as they mentioned in the recent literature, they suggested to be higher than yes, it is proven to be higher than general population, but they suggested to be higher than the one reported in the literature. And they said it is being underestimated. Breast tissue can be used as a diagnostic sample for Lynch syndrome, especially when colon or endometrial tissue is not available. Okay. Any comment regarding breast Lynch syndrome after presenting these cases before going to our case? Again, what do you think about this, Mr. Ghassan and Dr. Nadia?
That's That's interesting, of course. Now, just we need to bear in mind that having a genetic test for one of any genetic mutations which can increase the risk of breast cancer always have a range. So when you do say the BRCA gene, BRCA positive patient, you say the risk can range from 40% to 85%, and that range comes from like the family history. So someone with BRCA gene mutation with no one else in the family had breast cancer is different from someone with mutation but has like 5 members of breast cancer. Therefore, the panel for genes here in UK for patients who are suspected with increased risk of cancer, like high risk, those who are eligible for genetic testing. The panel which they do here includes the BRCA genes, the PALP2, the CHEK, and the ATM, and I think 2 more genes. Now, if they came back as ATM, say, mutation positive, we wouldn't say immediately you are at high risk. To calculate the risk, we check the family history and everything, and then we come with recommendations. Some of them, they don't need anything. They will still be at population risk or just moderate risk. Therefore, from what you presented now, looks like, and as what Dr. Nadia said, with more cases, Lynch might be included, but it doesn't mean that Lynch patient with Lynch cancer, they will be considered at a high risk of developing breast cancer, maybe increased risk. In the future, we'll know, but it all depends on the really family history. So you presented many cases now, and if we check if they had a family history of breast cancer, this might be added to this, to being known with Lynch syndrome, and then at that case, they might be included in the increased risk for breast cancer.
Yeah, we mentioned of some of these. They have in their history, they have family history of breast cancer. Not all, but some of them mentioned to have family history.
Yeah, and that will differentiate them because Lynch syndrome is not common, but it's not uncommon.
Yeah.
And of course, they will be screened for colon cancer, ovarian, endometrial cancer, which are more common with Lynch syndrome. But definitely, with what you presented, like patients with Lynch, if they have family history or strong family history of breast cancer, maybe they will be considered at increased risk for breast cancer.
The recent articles, all of them, they mention that underestimation, and they recommend more studies. They have said that there are no much, more. They didn't dig deep, okay, in such case, and there are no much, dedicated study regarding this syndrome before. And they recommend that.
Yeah, that's
what have been written in the literature, huh?
I said that's interesting. That's really good. Thank you for presenting those cases.
Okay, thank you. Okay, why do we present Lynch syndrome, and why do we present our case today? I want to emphasize a significant case of a possible synchronous cancer involving the ovary and colorectal cancer, and this is an infrequent occurrence that requires immediate attention. Okay, I have been faced with 3 different cases in my practice that are suspicious of Lynch syndrome, 2 outside Sudan and 1 at Ssbi University Hospital. But unfortunately, I have lost 2 of them with much of my material because of the war. And I have the 3rd one here. I'm going to present it today. This patient, when they presented to radiology department from an emergency department, from ER, to rule out intestinal obstruction. we don't know exactly why they suspect intestinal obstruction because of overdistension or distended abdomen, or the patient presented with pain, or what exactly they did not explain or in the request, just only written to rule out intestinal obstruction. Okay, what we can see here, a large pelvic abdominal mass, complex mass lesion is seen, enhancing with soft tissue. Okay, let us go back. This is the mass, okay, pelvic abdominal mass, very huge, okay, extending from the pelvic, going up into the abdomen, up to the umbilical and above umbilical region, and posteriorly to the level of L3. Okay, it is a complex, demonstrate here papillary projection and thick septation, which are enhancing. Okay, and here we can see it has the pedicle inclined toward the right adnexa. Can we see? This is the pedicle here. Okay, inclined toward the right adnexa. Sorry for not being, yeah, here, this is these are the vessels, okay? And so the vessels coming from the right adnexa tell us that this is the lesions and it is texture and these things, that is the right adnexal mass. This is its origin. So help us in diagnosing the origin of the mass. And there is also vessels following the ovarian, okay, from the aorta coming down, supplying this mass. Also, what we can see here, there is associated thickening, okay? Here we can see associated thickening of the round and the round ligaments, okay? And there is ascites, small ascites, we can see it. And obviously here we can see extensive liver metastasis. And this metastasis with elevated right hemidiaphragm, and even the diaphragm is seen to be infiltrating, invaded. The lung was free, but there was nodules or lymph nodes, small lymph nodes in the pericardial region. Here in the abdomen, we can see some small lymph nodes, okay, in the pelvic and para-aortic region. Okay. Can I ask you, why do I suspect or I raise possible Lynch syndrome rather than go if this is an ovarian cancer or ovarian lesion? Yeah, it's having high suspicious features for malignancy, though CT is not an optimum modality for ORAD classifications, but with these features, it is corresponding to MRI ORAD 5. It is almost very high risk for malignancy. So this is a classic malignant ovarian large mass. If we think about genetic affections of the ovarian, we'll think about BRCA and we'll look for the breast. But why? What do you think? Why I start to think about I will raise possible Lynch syndrome, or looking for something that might lead or might guide us to raise the possibility of Lynch syndrome? Why have I thought about Lynch syndrome in this case? What do you think? Radiologist. Any suggestion? Okay, here this is a mass. Can you see one feeding vessels from aorta, and the other, this is the vessels or the pedicles. These are the pedicles here going from the right adnexa. Okay, and the thickening of the broad and the round ligament on the right side, which all features are suspicious. But okay, because of this extensive liver involvement, yes, the peritoneum is involved. There are lymph nodes, but as there is significant disproportionate of liver involvement to peritoneal as well as the adenopathy. Usually what we have seen in our practice, the ovarian lesions involve the pelvic as well as the pre-aortic lymph node before going to other organs or distant metastases like the liver and the peritoneum. See the involvement of peritoneum before going to the liver or to the lung or bones or whatever. But the presence of these extensive liver involvement make me search for any bowel involvement that might be the cause of the involvement or infiltrative liver lesions, metastasis. And here I can see, can you see, this is the mass, this is the ovarian mass, and posterior to it here, this is a sigmoid. And adjacent, the adjacent segment, it was free, fortunately. So as not, it is not infiltrating, direct invasions. Far away, here I can see asymmetric, circumferential or near circumferential thickening. And these segments here, can you see it here again with adjacent, okay, soft tissue here and the vessels, and this is adjacent regional lymph nodes. This is irregular. Can you see it here more? This is the thickness of the wall up to 1.5 centimeter, and this is the adjacent soft tissue, amalgamated soft tissue like group of lymph node matted together, and nodular peritoneal mesocolonic infiltrates. Can you see the mesocolon infiltrate? And this is the enhancing mass. It is far away from the adjacent to the ovarian mass. Okay, so here again, this is the lesions. This is a rectosigmoid. This is a rectosigmoid mass taking more than 5 centimeter segment, and this is the adjacent infiltrate, not related at all to the ovarian mass. So could it be metastatic lesions in the colon associated with ovarian cancer?
It could be.
It could be, yes.
It could be. You cannot rule it out.
Yes, it could be. It could be metastatic, yes. طيب. يعني it is not direct invasions, but it can be metastasis.
Yes.
Okay, so it can be metastasis. Could this ovarian lesion be a metastatic, a metastasis from a colorectal cancer?
Oh.
The reverse.
Yes, ovary is a site of secondaries, metastasis, lakin
Yeah.
it's not that common
Yes, yes.
from
And
colonic.
usually it will be bilateral and even disproportionate. The size of the ovarian mass is disproportionate to the size of the
Yeah.
colorectal mass. Less likely. It can be, still it can be, but less likely. So Lynch
Yeah, and
syndrome,
for this size, the other ovary would be involved.
yeah,
Because
the
when
other
the
ovary
size,
would be, if it is
yeah,
metastasis, the other ovary would be involved.
yeah, especially with this size.
Especially with this size, yes. But in general, usually metastasis involve both generally. But and even with this size, expected to be the other side to be involved.
Yeah.
Okay. Okay. So Lynch syndrome is the most compelling possibility in this case. And explanation is that while it is feasible for metastatic colorectal cancer to originate from an ovarian primary and vice versa, Lynch syndrome stands out as the key concern. And female patients with Lynch syndrome face a significantly increased risk of colorectal cancer alongside highlighted susceptibility to gynecological cancer, particularly endometrial and then ovarian cancer. As we mentioned earlier, the endometrial cancer lifetime risk is up to 70%, while the ovarian about 12%. In instances of synchronous colorectal and ovarian cancer, Lynch syndrome is unequivocally the most likely cause. We should not go for, if we have a synchronous or metachronous ovarian along with colorectal cancer, Lynch syndrome is the most likely cause. It is unequivocally the most likely cause, leading to both simultaneous and sequential occurrence of these cancers. The patient in this case, who was radiologically diagnosed with ovarian and rectal cancer at the age of 47 years, aligns perfectly with the typical age of Lynch syndrome associated cancers for both. And while metastasis is a consideration, the prevalence of Lynch syndrome in synchronous colorectal and ovarian cancer decisively make it the more probable cause. Okay, so this is the same patient. What do you think is the peritoneal metastasis from the colorectal cancer or from ovarian cancer? Which one? What do you think?
الأوفيريان اللي بيعملها أكتر.
Okay. Do you agree all or someone have another suggestion? Both. In such case, peritoneal metastases, we cannot tell these peritoneal metastases are from ovarian or from colorectal. Both are commonly given. Do you remember one case, Dr. Nadia, before, the challenging case, and there was a dilemma in the diagnosis? She was presented with peritoneal metastasis. They had taken biopsy and reported to be colorectal, while imaging was suggesting that it was ovarian. And she was the relative of Dr. Rabab, oncology doctor, our colleague, and reported, we were insisted that the origin was because on imaging the colon completely free, okay, and she had bilateral ovarian lesion, and we said to repeat the pathology repeated, and they said, was a colorectal endoscopy performed and was free, but they insisted to give her a neoadjuvant chemotherapy for colorectal, and she didn't respond. Then they went for operation and they remove the bilateral masses and proven to have bilateral mucinous adenocarcinoma. The presentation of the peritoneal metastasis is more or less equal in both colorectal and ovarian cancer and can make a dilemma. So what? Hasn't she already been a cancer patient? Why we should raise a possibility? And what is the importance of saying that this might be Lynch syndrome, or just she might have just 2 metastases or two cancer, and that is it? What is the clinical relevance? So this case underscores the importance of caution in identifying similar cases in our practice. We have to think as a radiologist, just not to be to have a descriptive reports. We have to share in the management of the patient and to suggest diagnosis, and we have to think about the factors that raise the index of suspicions if the patient young age of cancer than expected, or there are incidental imaging findings of synchronous or metachronous cancer. We have to think about such type of genetic or familial cancers, and if the families member of the family have cancer than expected, and this might include colon cancer, endometrial, and other types of cancer as we mentioned earlier. Okay, so the recommendations for the care of the patient who might have an inherited predisposition to Lynch syndrome. The sporadic, definitely the genetic or the Lynch syndrome associated cancer is different from the sporadic counterparts in clinical features, radiology, pathology, and definitely it will impact the cancer management. Okay, there are many different features between the two, so it is important for us as a radiologist or pathologist or clinicians or whatever, we have to be aware of potential for Lynch syndrome. Not only can they often be misclassified as sporadic, resulting in an underestimation of their incidence, but also it is going to affect their management. And they have definitely, since it will be genetic, they have to take care also of the family members and to screen the patient and their family. So how to diagnose the patient with Lynch syndrome? A combination of family history, clinical criteria, and genetic testing, confirming the diagnosis, and definitely like sporadic imaging can play a role in such cases. So for the diagnosis, there are many criteria, clinical criteria to select patients that might have Lynch syndrome for further genetic testing, Amsterdam 1 and 2 criteria, and Bethesda guidelines. And the Bethesda guidelines, it's seen here. These are the criteria, 5 criteria of the Bethesda, and required to fulfill one of the 5 to necessitate an evaluation of a tumor for microsatellite instability or to aid in diagnosis of Lynch syndrome, which include colorectal cancer diagnosis less than the age of 50-year-old, presence of associated Lynch syndrome cancer or tumors, histology of colorectal cancer, indicative of microsatellites instability in patient less than 60-year-old, colorectal cancer diagnosed in a patient with at least one or two one first or second degree relative, okay, with Lynch syndrome cancer diagnosed before the age of 50, or a colorectal cancer diagnosed in patient with at least two or more first or second degree relatives who have Lynch syndrome associated of any age, okay? So what are the Lynch syndrome testing? The genetic testing, which are definitive diagnoses. As we mentioned earlier, the genes included are MSH2, MSH6, MLH1, BMS2. This helps identify carriers of syndrome and guide their management of cancer risk. Also, number one, as we mentioned earlier, is colorectal cancer. So colonoscopy for screening annually is recommended, starting at the age of 20 to 25, but can be earlier by 2 to 5 years before the youngest age of diagnosis of colorectal cancer in the family. And if the patient youngest age it was 20, they might start at the age of 15. And to be repeated every 1 to 2 years. Endometrial and ovarian cancer recommend to do pelvic examination, transvaginal ultrasound, and CA125 measurements. Other cancers, upper endoscopy for the gastric and small bowel jejunal cancer, urine analysis for urothelial, and screening mammography imaging with an increased risk of breast cancer in individuals with Lynch syndrome. The radiographic imaging plays a crucial role and diagnosis in this context. And the organ-specific cancer risk and associated screening vary according to the sex of the affected individual and the type of germline being affected or alterations causing the microsatellite instability. And Lynch syndrome associated cancer typically exhibit DNA microsatellite instability and loss of expression of mismatch repair proteins, as we mentioned earlier. Dr. Nadia, do you like to comment on this image? It is a gift for you.
It's a beautiful example of immunohistochemistry. Because we can do these we can test for these genetic germlines by immunohistochemistry, which makes it very easy because most of the labs now have established immunohistochemical ability. Now the first one, this
This
one
is A, yes.
this is A. It shows you that it's a nuclear staining, because immunohistochemistry always takes the stain as a brownish stain, and it is mostly, this is the standard, it takes the brownish color, and it depends where in the cell it is taken. So here it is nuclear, not cytoplasmic or cell membrane. You can see it is in the nuclei, and it's quietly dark staining, so it's a strong stain. And this shows positivity for MSH2. You always have to have the explanation of what this marker is, because otherwise it's not special. It doesn't have a special color, it doesn't have, but this one is positive. You can see the brown stained nuclei, and this is consistent with normal MSH 2 expression. So the explanation of the slide is very important. The second one shows a high power view for and the immune reactivity.
So it is not defective? Do you mean it is not a defective one?
It, in the first one, it's not defective. That's why all of them are stained. But in the second one, you can see that the cells are negative. You can see a few positive cells that are brownish, but the other nuclei are taking a bluish stain. And this is considered negative. And the negative shows loss of MLH1 expression. There is no MLH1 reactivity in this section.
That means it is defective?
It is defective. It is not there. That's why the specimen is taking the counter stain, which is the hematoxylin eosine, a blue-gray stain. You counter stain for the negative to see it. Otherwise, you will not see it. Here you can see that most of the nuclei, instead of being dark brown, they are actually bluish gray, showing that the cells have not taken the stain for MLH1. And that's why this tumor has a mutation in MLH1.
Yes, this is what my questions. Now you explain it to me. So the defective one is MLH1.
Yes, at least in these two slides. The first one is positive, the second one is negative.
Okay, so the first one is normal, and the second one is the affected one.
Yes. And this, but the second one, B, it shows you that the nuclei are negative. So this tumor does not have reactivity for MLH1.
So this, that means this tumor is Lynch syndrome in a gene in germline MLH1.
Yes.
Okay, thank you. So the management, definitely early detection and treatment are crucial. Prevention is better than treatment. And as we mentioned earlier, we have to screen, genetic testing, early treatment. An individual with family history of Lynch syndrome has to be or should consider genetic counseling and testing. And we have to consider also lifestyle modifications to avoid factors that can increase gene mutations like smoking, alcohol, and they have to have sun ultraviolet light protection, avoid overweight and obesity. And there is literature mentioned that aspirin used, there is aspirin can be used to protect against colorectal cancer. And definitely the treatment for Lynch syndrome, it depends on the type of cancer, if it is colorectal partial or total colectomy, or for gynecological hysterectomy and bilateral salpingo-oophorectomy. And sometimes they can consider this type of surgery as preventive measurements. And definitely when it will be successful when the cancer detected early. And the preventions, in the preventions, the universal testing of colorectal cancer for microsatellite instability is now recommended to prevent cases of Lynch syndrome from being missed owing to the use of clinical criteria alone. To reduce morbidity and mortality among relative affected individuals and to guide for management decisions. Okay, and over the past decade, significant advances have been made in understanding Lynch syndrome, and as we mentioned earlier, it is the most prevalent hereditary syndrome, significantly increasing the risk of colorectal and endometrial cancer with less involvement or less risk of other malignancies, and is associated tumor alongside any Lynch syndrome associated tumor alongside colorectal cancer clearly confirm Lynch syndrome as a cause. synchronous ovarian and colorectal cancer are firmly linked to Lynch syndrome, emphasizing the essential role of genetics. These cancers are typically diagnosed with 6 months, necessitating an effective multidisciplinary treatment. And in young patients, metachronous ovarian and colorectal cancer are definitive indicators of Lynch syndrome that demand immediate action, synchronous and metachronous. It is imperative to prioritize screening and prevention of gynecological cancer to ensure early detection and effectively mitigate the cancer risk associated with Lynch syndrome. And additionally, Lynch syndrome related cancer can appear with rectal cancer a decade later, underscoring the need for vigilant monitoring. Recent studies reveal a significant connection between breast cancer and Lynch syndrome, highlighting the need for further investigations. Did you hear Dr. Ghassan? Are you there, Mr. Ghassan? This sentence? He left? Okay. A recent study reveals a significant connection between breast cancer and Lynch syndrome, highlighting the need for further investigations. Prioritizing the prevention and early detection of gynecological cancer is crucial to mitigating the increased risk associated with Lynch cancer, and by enhancing diagnostic methods and providing thorough genetic counseling, we can significantly reduce the incidence of Lynch syndrome related tumor. And the current recommendations regarding cancer screening and prevention require careful consultation between clinicians, clinical cancer genetic services, and well-informed the patient. And here, these are my references. Okay. And thank you very much.
Thank you. This was very interesting.
Thank you, Dr. Nadia, for your participation. And
you are welcome. You're so welcome.
any question? Mr. Muhammad Al-Fatih is here now. You are welcome, Mr. Muhammad. Long time we didn't see you or hear from you.
Assalamu alaikum.
Wa alaikum assalam wa rahmatullah.
Thank you very much, Dr. Rabab Ballah. Very interesting. Yes, it is known for other associations rather than breast cancer, but this may be new for Lynch, for the association between Lynch and breast cancer. It has a stronger association with others, well known, like colorectal, small bowel, gastric, prostate, ovarian, endometrial. But for breast cancer, this is very interesting. Thank you very much. I joined late. I'm sorry, but that's why I was working. But
no problem. You are welcome at any time.
It's
yes,
very nice. Thank you.
We have mentioned that in early on. Yes, the association colorectal cancer, the lifetime risk for colorectal cancer in Lynch syndrome is up to 80%. And for endometrial cancer is up to 70%. Ovarian, 12%. These followed by gastric, and urothelial cancer. Among other, less, the other cancer, but every time they found, they discover a link between Lynch syndrome and different. Now, recently, even they have mentioned that they are studying a link between thyroid cancer and Lynch syndrome, particularly papillary carcinoma. They said there is a link between papillary carcinoma. And regarding the breast, they have mentioned that even it is underestimated. The relations of Lynch syndrome with the breast cancer is underestimated. Okay, and they recommend further study regarding this. And they mentioned also that the breast tissue can be used if there is no available colonic or endometrial
Biopsy.
tissue to test for micro instability. They can use the breast instead.
Okay.
And even they have mentioned that it is the commonest extraintestinal presentation of Lynch syndrome.
Okay. Good. Nice. عندي بس سؤال لدكتورة نادية بالنسبة
Yes.
للجينيتك تيستينج واليوز اوف immunohistochemistry في this يعني
أيوة.
نحن طبعا في السودان لسه ان شاء الله يعني ربنا يصلح الاحوال قدام الناس ترجع وتستقر وكده، لكن الحاجه دي اللي بيمنع شنو في السودان؟ انه عندنا مشكله في الجينيتك تيستينج في السودان. يعني هي صح ممكن تكون مكلفه وكده، لكن هل في اي حلول؟ هل في اي حاجات اقل تكلفه ظهرت؟
definitely. ونحن عندنا مشكلتين. الفحوصات البروجريشن بتاع الفحوصات دائما بيظهر في البرايفت قبل الحكومه. دي برضه مشكله كبيره. فبيزيكلي حاسه ان احنا غير مستشفى الذره مثلا في البريست ما كان عندنا immunohistochemistry الا في الذره وفي حتت بسيطه، الباقي كله في البرايفت. دي is a very big problem. الحاجه الثانيه الكويسه انه if immunohistochemistry is established, which is a must for a laboratory. يعني ما ممكن حس اللابراتوري بتاع هيستو ما يكون فيه immunohistochemistry عشان في الريبورت is completed by immunohistochemistry. Not just to diagnose the case, it is actually for the prognosis. Like in breast, you cannot complete a report unless you have minimum the 4 immune that have to go into each report of the breast. So the establishment of immunohistochemistry labs is very important. Once you establish them, it is very good that a lot of these genetic markers are now being tested by immunohistochemistry. But here it's being made easier for you to test for genetic changes. But in the end, genetic laboratories لازم برضو to be established. Eventually they have to be. We don't have them. There is one lab which started with Dr. Imad. Imad, I'm sorry, I don't remember the name, but he started, and again, it was a private lab. And this is the main problem. These are things that should be established. For example, in Khartoum, the state, they should be at the public health laboratory, FISTAC. They should be available there in access to everybody.
Do you like to comment دكتورة نادية على السلايدز الأولى اللي قلت لك نخليها لك على الآخر؟
كده نشوفها، لكن افتكر هي ما مهمة in this respect شديد. يعني هي بتوري ما مهمة شديد يعني بالنسبة للكيس هنا.
خلاص. No, if it is not important.
I hope I answered your question دكتور محمد.
ثانك يو فيري ماتش. والله بس يا ريت بعدين غايته الواحد بيتوقع انه بعد شويه في السودان ممكن يكون في دعومات وكده، فالناس من الاول يعني تستابلش حاجات كويسه من البدايه.
يعني انت عشان to establish an immunohistochemistry lab in your laboratory of histopathology, it costs so much more than histopathology. ونحن at the moment عندنا مشكله في الهيستوباثولوجي ذاته. يعني لو عديت example مثلا لما نحن كنا لسه هناك مثلا قول الاميونوهيستوكيمستري ب 2000، بندفع 2000 في التست دي في الحكومي. البيشنت بيدفع 2000 في الماركر.
Thank you دكتورة رباب محمد الحسن. On behalf of Sudanese Society of Breast and Women Imaging, we remain committed to fostering knowledge and collaboration within the radiology community and the multidisciplinary teams. Please stay tuned for our upcoming educational event Thank you, Dr. Rabab, for that informative and thought-provoking presentation on Lynch syndrome. Your insights into the radiological perspective and its impact on women imaging have been truly valuable. We also extend our sincere thanks to all attendees, especially Dr. Nadia Dawi and Mr. Mohammed Al-Fatih, and all
Mr. Ghassan.
the participants, Mr. Ghassan, for joining us today and for your active participation. Until then, stay safe and continue advancing in excellence. Good night. Thank you all.
Thank you.
Thank you very much.